On, Nikki?
We are being recorded, everybody.
Yes. Mm-hmm.
Okay. Good morning, everyone. I'm Maria Volpe. I'm a professor at John Jay College and director of the Dispute Resolution Program. Welcome to our monthly breakfast for dispute resolvers. These breakfasts are co-sponsored by the Association for Conflict Resolution of Greater New York and the CUNY Dispute Resolution Center at John Jay College. This morning is breakfast number 234. We're now in our 20th year of these breakfasts. For those of you who are new and this is your first breakfast, I started these after 9/11. We met in person until March at John Jay College.
March of last year.
Long time
In the
ago.
last day.
We're going to have to remember that, especially next month, because it'll be March again, right?
It'll be a year.
And since April, we have been virtual. These breakfasts are recorded, as we mentioned just a minute ago, and they are housed on the ACR-GNY website at www.acr-gny.org. Those are only the breakfasts since April. To participate in this breakfast this morning, you'll get more instructions. You can either raise your hand and we will call you in that order, or we will be monitoring the chat. Feel free to leave a message or a comment or a question there. And the co-hosts will be monitoring that and helping the speaker with those questions. Each month, these breakfasts are organized by a wonderful team that I'm a part of. Julie Denny, Chuck Newman, Matthew Latimer, and Nikki Borofsky. We couldn't put on these breakfasts every month without everyone's efforts. So thank you, everyone. And they're all serving as co-hosts this morning for this breakfast. I'm going to turn this over to Julie, who will introduce our wonderful speaker, who's going to talk about an important topic.
Need to mute everybody.
I'm gonna mute everybody so that anybody who wants to speak can unmute themselves afterwards.
Okay.
So Maria, you need to unmute yourself and Julie as well.
Okay, got it. All right, so Khalid Raymond is our speaker this morning. He has an incredible list of credentials. I am not going to go through all of them, but I'll tell you that he is retired after 38 years of practice as a clinical and academic doctor and a fellow of the American College of Physicians. He's board certified in 2 subspecialties of internal medicine, hematology and medical oncology. He's taught, he's written. He's an interesting guy who came to America from Pakistan in I think the 60s, 1969, to pursue additional training here. And except for the occasional visit home, he hasn't left. His wife spoke to us several months ago. She's on the call right now. Khalid has also chaired many medical societies and served as the president of the Academy of Medicine in Richmond and the medical director of the Richmond Hospice. He has a very colorful, wonderful history. But right now, his feeling is that promoting best care at the end of life is a huge passion of his. And he wrote me because I met them 2 years ago at Chautauqua in the summer. And he said, I have an idea. I think your breakfast attendees might be interested in end of life issues and the conflict that arises around them. So I am delighted to welcome Khalid Raymond. Take it away, Khalid.
Thank you very much. Thank you, Maria and Julia, and the organizing committee of the ACR-GNY for inviting me this morning to speak to you. I hope and pray that everybody is well. And I also want to extend my condolences to anyone on the call who may have been affected by the pandemic or may have lost a loved one. The topic of discussion today is mediating medical issues at the end of life. End of life brings to us numerous challenges, and each challenge or each issue, there is a potential of conflict. I'll just enumerate some of them, and then we will get to the point of focus, which is today's talk. How much time is left is a very commonly asked question. You know, the physicians don't know the future, and they cannot be very precise in predicting when the end will come. However, many of us in my field particularly have learned over a period of time through our clinical work, we can make a guesstimate, we can make an educated guess. But I have to tell you that after 25, 30 years of practice, I have been wrong many, many times. How do we communicate the bad news with the patients, and how much do we communicate? That is another issue that can lead to discomfort and conflicts. And it's also difficult for the professionals. It's a skill that needs to be taught. And I, during my academic work, has been teaching this to the oncology fellows as to how to communicate the bad news. There's a lot of literature on it. There are a lot of articles on it. There are algorithms on it. And we will go into the details, but I want to point out that the setting in which we communicate these news is very important. The privacy is very important. And what is very important is to find out how much the individual already knows, so that you know where to begin. The last thing that we do in any communication, whether it be end-of-life issues or writing a prescription for the patient, is to ask them to repeat what they heard. Because very often people will tell you something which you never said. So we ask them to repeat, if they may, as to what they've heard and what they understood from that conversation, from that communication. So that is an important component of that. How much do we tell? And that also depends on how much do the patient wants to know. How much do they already know? And sometimes they are very tricky. They know it, but they don't want to admit they know it. So as an oncologist, as a cancer doctor, particularly dealing with the end-of-life issues, it is something that we have to gauge during our conversation with the patient. How much is that they already know? And how much would they like to know? It's very often when I talk to the patients, they say, oh, don't tell me anything. Talk to my wife or talk to my husband. I don't need to know. Of course, that is their wish, and in which case you have to navigate as to how to approach the situation. But you know, it is driven by the patient's desires. So we have to, how much do we tell them? Because you know, it has been a source of conflict. The families have come up and angry, but why did you tell them? Well, the patient asked. The patient wanted to know everything. And I had to tell them I could not lie. So that's where the families get very upset. They said, well, all this time we've been telling them, oh, you just have a little inflammation, little bronchitis, nothing more. But now you've told them that they have lung cancer. So this is another source of conflict that can arise at the end of life or in a serious illness. What kind of treatments can we offer at the end of life? Do we continue aggressive treatments? Or do we switch over to something more about comfort care? Again, again, a major source of conflict between the patient, the family, the caregivers. Obviously, the family and the caregivers don't want to lose someone, and their basic approach is do more, because we want to see some positive results. And the other thing that I really abhor from my own colleagues is when they say, oh, there's nothing more we can do. So if you go to a cancer specialist at a big center, they'll treat you, and at the end they will say, well, now you can go back to your town or to your primary care doctor because there is nothing more we can do. In my book, that is wrong. There's always much more that we can do. It is that we do it differently. We switch from a curative approach to a palliative approach. We switch from the toxic chemotherapies and to a treatment approach which addresses the symptoms of the patient to make them feel better. So there is always something that we can do, and that phrase that, that there's nothing more we can do is something that the doctors should avoid using, because that is not true. Who makes the decisions? A big area of conflict. Does the patient make the decision? Do the doctor make the decision? Is it the healthcare proxy or the agent who's making the decision? Or more in the modern terms, do we do what's called the shared decision making? The patient has the right to make the decision in our legal system as well as in our cultural system. But many of the times the patients will not make a decision, and they will leave it up to the others, which is unfortunate. But again, that is their right to sort of defer it to someone else. But there was a time when doctors made all the decisions. They were like God. They told you what they wanted to do, and there was no discussion about it. You couldn't even question them or discuss about it. Those times have gone. We are now in the era of shared decision making. However, there's a very important thing to remember in the shared decision making, that the patients cannot make an informed decision if they don't know what's going on. So they need to know all the ins and outs. They need to know what the options are so that they can make an informed decision. And that becomes very difficult because it is a challenge. Some patients don't want to know. Some family members do not want to tell them the details of what's going on. And without that, the patient cannot really make an informed decision. And so can the patient not make a decision, even if it's a shared decision making. How can you discuss things and make a shared decision if you don't know the truth, if you don't know the details? And that is a major issue in the practice of medicine, particularly in oncology, because family in their own way, protecting the patient, or for whatever reason, do not want the details to be shared with the patient. And if the patient doesn't want to know, that makes the job of doctors like me when I was in practice very difficult and can be the source of conflict. What I do and I have done in the past is, let me back up a little bit. So sometimes some of the doctors will say, well, you have 3 options, option 1, 2, and 3, pick and choose. And to me, that is not fair either, because the patients have the autonomy and they can make the final decision, but they may not know the intricacies of the 3 treatment options. Is the toxicity more than the benefit? Is my medical condition, my diabetes, my hypertension, my kidney condition, is that appropriate for a particular treatment? So that my approach has been, and many of my colleagues' approach has been, that we discuss various options, but we do present our opinion, our preferred choice to the patient based on their clinical condition, but then leave it up to them to make the final decision. It is their decisions to make, but they need to be guided and they need to be educated. And if it is possible, with the permission of the patients, to include the family in this discussion, that makes it easier because then there's less of a conflict. They know that the patient asked the questions, wanted to know, got the answers, and then made the informed decision. None of them is easy because sometimes the patients, as I said earlier, don't want to know, and sometimes the family doesn't want to know. How do we define death? A huge area of research and huge area of potential conflict, particularly from a cultural and a religious point of view. It also has legal implication when you declare somebody dead. It has, there are rules and regulations about definition of death in individual state, in individual countries, even internationally. There are major differences in how death is defined from nation to nation. And to that effect, there's an international gathering or a group of specialists and neurologists who have been working together to develop what's called the Whole Brain Death Project. In the United States, in order to sort of standardize the definition of death, an act was passed in 1981 called the Uniform Declaration of Death Act, UDDA. And that was then accepted by the American Medical Association as well as the American Bar Association as the definition of death. Under this act, the person is legally dead if there is irreversible cessation or stoppage of circulation and respiratory function, which is the heart stops beating and the breathing stops, or there is irreversible cessation or stoppage of all functions of the entire brain. Now, today is not a talk about what is the entire brain, what is the upper brain, what is the lower brain, what is the brainstem, but these are issues that come up if the patient or the family or the legal representative raises those issues. One can simply go by stoppage of the heart, there's no pulse, spontaneous pulse, there's no spontaneous breathing, you wait and so forth. So that is one way to do that. And some of the nations of the world where the technology is still very primitive, perhaps this is the way the death is defined. This particular group of the international experts just recently published a paper in August of 2020 in the Journal of Medical Association, in which they propose a very detailed description of the discrepancy, the differences in different nations, and propose a way forward to have some sort of a universal definition of death. Now, all of these things can lead to conflict, but we don't have time to talk about all of them or any one of them because we are going to focus on our topic of discussion today, which is to mediate and the end of life, and my focus will be more on advanced directives. Now, before I go there, I want to share with you something that you already know, that our healthcare system has changed significantly. There was a time when our primary doctor knew us. He knew the family, he or she knew the family. He or she knew the philosophy of the family. Those doctors are no longer in independent practice. Many of these practices are now group practices, and many of the groups are actually owned by the hospitals or other corporations. The old-fashioned family physician is no more, unfortunately. When we get admitted to the hospital, we get cared by a rotating cadre of doctors called the hospitalists. They work shifts. They don't have the time to pull up a chair and sit down next to us and get to know us. They know our disease. They know our numbers. They can go to the computer and sit there and look at our reports, our lab results, and our x-rays and so forth. They know that very well, but they don't know us as a person. They don't know what we feel, how we feel, what do we want, and so forth. So that is a major shift that has created another, I would say, an adverse impact on the end-of-life care and to sort of have a smooth, with no hurdles towards the end. So that is a major shift, and we have to keep that in mind. Now, let me just share with you two stories from my own private practice, which I think will help frame this discussion. I remember a lady with very advanced ovarian cancer. We had been treating her, but towards the end, the water was filling up her chest cavity. It got to a point that I had to get someone or tap it myself every day just to make room so that she could breathe. Things got so bad at one time that we had to intubate her because she could not breathe on her own. There was not enough room in the lungs. You needed the machine to breathe for her. She was awake, she was alert, but of course she could not speak because she had a tube in her throat. After a few days being on the ventilator, she communicated with me by writing. And she said that she wants to be taken off the ventilator. Now, she knew that she would not survive without the ventilator. She understood that. I spoke to her. She understood it very clearly. But that's what she said was that before I die, I want to be able to speak. I want to be able to say goodbye to my family. She was awake and alert and completely competent. Of course, I reached out to the appropriate parties in the hospital to make sure that they were witness to this, that they had also interviewed her, and that she was in her clear mind that she wanted to be taken off the ventilator. So at that point, I took her off the ventilator, the so-called unplugged the machine. She was able to speak. She was able to say her goodbyes. And later that day, she died peacefully with her loved ones around her in the hospital. I also remember the story of an older gentleman who was under my care for years. He had advanced cancer. And when his condition got worse, he was hospitalized. But when he became more incoherent, I asked for a family meeting. Now, he had not appointed any healthcare proxy or a healthcare agent and had no advanced directives, had no living will. We had a conversation with the family, the wife, the daughter, and another family member, and they all agreed that it was time that we switched from the aggressive, curative, toxic treatments over to more palliation and comfort care. A few days later, a tall, strapping young man in cowboy boots walked into the hospital. I happened to be on the unit that day. He became terribly upset when told that his father had been switched from a curative approach to a palliative approach. The son had not been in the picture all this time. I didn't even know that this gentleman had a son. But here he was, and he demanded a different course of action. He became very loud, he became angry, boisterous, and became pretty much threatening, not just to me, but to his mother as well. Now, could this have been avoided? I would say yes. This could have been avoided or at least mitigated and somewhat diffused had the patient created a living will while mentally competent and had assigned a proxy or an agent to express his wishes. So end of life is a very difficult time. And you will all agree with that. It is difficult for the patient. It is difficult for the family. This is a very stressful time. This is a time when we need to come together lovingly, holding each other's hands. It's not a time for fighting and bickering among the family member, but this is exactly what happens more often than I care to know. I've seen families torn apart and siblings who become estranged from each other for the rest of their lives at the end of life of their parent or their loved one. Now, many of you are experts at conflict resolution and mediation, and you may be called upon to mediate in such problems, but I think that you will agree that it is better if we can avoid having such conflicts in the first place, rather than having to resolve them later. And that's what we will try to do today. Now, when we are kids, decisions are made for us. But once we grow up, we take charge. We make our own decisions. And certainly not a single day goes by when we don't decide or plan one thing or the other. But very few of us plan for the end of our life and the medical care at the end of our life. Why is that? Now, there can be many reasons. Thinking about death and dying is difficult, I have to admit. Talking with our children and loved ones on this subject is even more difficult. The minute we start such a conversation, the kids say, oh, well, let's not talk about that. You're not going anywhere. You're going to be fine. You'll be okay. Let's talk about something else. And they shut the conversation down. It is very unpleasant and it is painful to have these kind of discussions. But, you know, we have had tough discussions and tough conversations all our life. And end of life discussion should be no different. It is something that we must have. So here's something that I have practiced in my own professional life. The first thing I would do is to, before I talk to others, as a patient, let's say, I have to talk to myself. What do I want? What kind of medical care I will want to have at the end of my life? Will I want continuous aggressive treatment? What will be, when will be enough? Enough is enough. When will I be ready to let go? What will I want to be kept alive on machines, medications, and tube feedings? And there are people who wish to say that, who wish to do that, and they're very clear about it, and that is fine. That is their choice. But because of the autonomy that we are given and the God-given right to choose, we need to do this. Now, we may need more information before we make our decision, and that's fine. And there are a lot of resources that we can use to get that information so that we are well equipped to think for ourselves, what is it that we want? You know, regarding when is enough, it reminded me of a workshop that I participated in years ago. One of my colleagues who was conducting that particular day asked the audience to describe what it will be beyond which they will not want to continue living. Now, each one, those who were willing to offer an answer, had a different answer. Someone said, well, I don't want to be kept alive if I'm unable to communicate. Someone said, I don't want to be kept alive with machines if I'm unable to recognize my own family members. And interestingly, one person said, I don't want to live beyond when I'm unable to laugh at a joke. So this illustrates that each one of us have a special point beyond which the life starts to become meaningless, and one would not want to extend it with artificial means. So once we have talked to ourselves, once we have thought it through, it is better that we write it down. Our ideas and thoughts of what kind of medical care we will want, if we write it down, that is what we call a living will. Now, a living will is not a legal document, but it is the clearest and the most authentic expression of our wishes regarding the medical care that we want at the end of our life. One can edit this living will as many times as we wish. We can write a new one every day and throw the old one out. There are many, many templates available on the internet to develop and create a living will, so that one can include most of the things that are useful to be in this document. We also need to think about having an agent or a healthcare proxy. We are in our control and we make decisions as long as we can make our decisions. But towards the end of life, very often, we lose that competency. We are no longer competent mentally to make those decisions. It is at that time that we need an agent or a healthcare proxy who will speak for us. So we also then need to think, who is it that we are going to appoint as our agent to speak for us when we are unable to do so? We should think about and create a list in our mind, write down the names, and then approach these people to see who is willing to be our agent or what's called healthcare proxy. Now remember that our physician cannot be our healthcare agent or a healthcare proxy, but any other adult can be. It can be a spouse, it can be an adult child, it can be a relative, it can be a friend, even a neighbor. Anyone who is willing to and is committed to be available and be responsible to carry out our wishes when the time comes. One has the ability to change the agent or healthcare proxy anytime. And this is a document which does not require a lawyer. It does not even need to be notarized. You just need to have 2 adult witnesses, and you must have had a conversation with your agent. And of course, if you have a living will, that becomes also a guide to the agent or to the healthcare proxy when the time comes. Now, once we have thought it through, once we have an agent who has accepted the responsibility, that is the time now that we approach to the family and have a conversation. Excuse me. The setting and the time is very important. The way I approach this, or I recommend that we approach this, is that we tell the family that by doing so, we are actually doing them a favor. By making a decision ourselves rather than leaving it to them to fight it over later on. It is the best parting gift that we can leave with our family. The discussion can start at a time when, well, let me say it this way. There is no good time to have this discussion. There is no one best time to have this discussion. But let's do our very best to find a time when there are no other pressing issues that need to be addressed. Let's find a time when we are healthy, when we are not threatened by a serious illness. To me, the best time for young people is when they graduate from high school, the very first time they sit behind the wheel of a car. So a good time is when death or the thought of death is not threatening. So we can have an open conversation, and the kid, and we cannot be stopped in that discussion. Again, there are many resources available as to how to approach it, what to say, what not to say. There are books written on it, there are articles written on it. And at the end of conversation, I'll share with you a book that I came across in 2014, written by a cartoonist, Roz Chast, who lives in Brooklyn. And she is the official cartoonist for the New Yorker magazine. And she had this situation in which she spoke to her parents and so forth. Another way to approach this, and once we have talked to the family and we have shared our thoughts with them, hopefully they will agree. There may be a conflict, they may disagree with the choice of the medical care that we have decided. They may disagree with the appointment of the agent. It is up to us to whether we want to listen to them, make changes, or stick to our choices, because at the end of the day, it is our decision. We have the authority, legal as well as God-given right to make that decision, and we can prevail. Again, we may need a mediator to calm down the temperature at that time if there is no end to this discussion. But this is all done way before the event which we are talking about, the so-called end-of-life care. There's another document that has become available lately. Almost every state has a similar document. I will talk about the one that is applicable to the state of New York. And these are called by different names. The one in New York is called MOLST, M-O-L-M-O-L-S-T, Medical Orders for Life-Sustaining Treatments. In other states, it's called POST, MOST, and so forth. But the idea is, if you want to find out what is offered by your state of residence, go to the internet and put in medical orders for life-sustaining treatments for your state, and you will get this. I will show you just the first page of that form so that you're looking at it and easily find it on the internet. This is for the New York State. The most important thing about this form is that this is actually a medical order signed by the doctor. So for that matter, it is a legal document which is binding on the healthcare team to follow the doctor's orders. The living will, as I mentioned earlier, is not a legal document. It's just a compilation of our wishes, our thoughts. What is it that we want? But it is not binding. The MOLST form, on the other hand, is a form which is like the doctor's orders in a hospital. This form is also portable, meaning that once signed, duly filled out and signed, this can move from facility to facility. If I'm transferred as a patient from one facility to the other, or from a long-term facility back to the hospital, hospital back to the long-term facility, this moves with me. So in that case, it is something that pretty much stays current. It is portable. the content of the form has to be developed in collaboration between the patient and the doctor. It is advised that if we live alone, that we keep this form in a very in a place that can be easily discovered, like on the door or maybe on the refrigerator. Many of these forms are actually, the original ones are printed on colored paper, bright red, fuchsia, or yellow, so that they stand out amongst all these other things that are on our refrigerator. So that these are easily available. And the reason being that if I live alone and I've suddenly suffered a stroke or I'm unable to communicate, but unfortunately, if 911 is called and EMS and the first responders come, they'll be able to see that. So this form will tell them who my doctor is and what the orders are before the hospital as well as in the hospital. So pre-hospital and hospital medical orders are written on this form. The MOLS form states on the top that this is for someone who wants to avoid or to receive any or all of the life-sustaining treatments. It is for someone who resides in a long-term facility and someone who may have a potential of dying within a year. So I think it's really good for everyone, but these are the kind of people or situations in which we should definitely consider having a MOLS form. The form has 6 sections. Section A deals with resuscitation instructions. Do I want to be resuscitated? Do I want to have CPR? Do I want to be intubated? Or I do not want these things. So the doctor has to say, do not resuscitate or enter the order of DNR into the records or into this form, which becomes part of the record. The next section, section B, is the name and the signature of the patient and the appointed proxy or the agent. So this is another place where the name of the agent can be entered. The patient signs it, and it is also requires that it be witnessed by 2 adults, the section B. Section C are the signatures of the physician or the nurse practitioner who has helped you develop this form. Remember that this is done, you cannot do it alone. You have to have the doctor or the nurse practitioner. So preferably either done in the doctor's office, or if it's in a long-term facility, physician is there at the bedside with you, or in the doctor's office and so forth. So they have to sign, they have to put their name down, and they have to also include their New York State license to make it an official binding document. Section D has a whole list of checkoffs. Do I have an advance directives? Do I have a billing will, living will? Do I have a healthcare proxy or agent? Do I want organ donations or not? So these are the kind of things that you check off, or you leave it blank, depending on what your wishes are. Section E addresses other life-sustaining treatments, and such as, you're still breathing, you still have a heartbeat, but you're still alive, but it is sort of anticipated that you may not live for very long. So what are the other treatments? For example, do I want to be kept alive over those days and weeks with artificial hydration, with artificial nutrition? Will I want to have antibiotics if I get sick or develop infection like pneumonia? Will I agree to have blood transfusions? Will I agree to have other limited medical interventions? Will I want to be hospitalized again after this particular hospitalization? So these are other things that we can enter into this form after consultation, of course, with the physician, and expressing our wishes. So this becomes a a document which includes all these other life-sustaining treatments that may or may not be administered. The last section, a whole page, has multiple fields, and that deals with the updates on this form. So, we create the form today, and we live in the adult nursing facility. We can update it every couple of months. Remember, it is the last form that is the legal and the binding one. So if things have changed, if our agent or healthcare proxy has changed, if our wishes have changed, we can do that, and we can then update this form. And that section F, the last action, gives us the opportunity to continuously update it. Now, remember, every time we update it or every time the form is created, we keep the original and our doctor keeps the copy. So it is very important that after doing all that, that the documents be available to the interested parties. It's no good to go through all the trouble and create it and not find this paper at the last minute. And that is what is often happens, because when something serious happens, suddenly, things get lost. We cannot find things that we would normally have found, or somebody walks into the house and they cannot find these things. So it's very important that these be communicated and kept in places which are easily available. We all know that sometimes we think we put something at a place that is the most safest place, but then 2 months later, we don't know where we put it. So that is an important issue with these forms or any other documents that we create, directing others what to do at the end of our life. Now, to make this even a little bit easier, a electronic form or e-most form has been developed. This form resides in the cloud. It is available on the internet. And again, it requires both the doctor and the patient's collaboration. And so the doctor's office has to have a software, or the hospital has to have a software, or the nursing home has to have a software of this particular entity. And then we can complete this online. We will have to update it also online, but it is more cumbersome, and not everybody has access to these things. Every facility may not have software, or they may not have installed this software, but it is very convenient because it is on the internet, and by providing a password, the healthcare team can easily access it. And even if we are moving from state to state, it can be accessed. Maybe even internationally, it can be accessed and can be a guide to the medical team as to what to do. And by doing so, again, we are reducing or hopefully eliminating any chances of conflict. So before I close, I just want to summarize again, like a take-home message. I hope that most of us have thought about it. I hope that most of us have developed an advanced directive, that we have appointed an agent or a healthcare proxy who will speak for us when we are unable to speak for ourselves. Maybe many of us have even developed and executed this MOLST form that is now available for many states, because this becomes really a medical order and becomes legally binding. Hope that many of us have taken the time to write down what our wishes are in the form of a living will. In fact, there are now companies available. Companies have come up who can help you develop all these things. These are private companies. You pay a fee to become to use their services. I have looked at quite a few of them. I'm not endorsing any particular one. One of them is called Everplans, Everplans, so everplans.com. But if you just put down end of life care, many of these companies' names will come up, and you can see what is it that they are offering, what are the fees. But that can also take a lot of the burden off our hands in developing these documents. Now, remember that we still have to have a conversation. In order to reduce the conflicts and the fights, we need to communicate these things as well. We can do all that to ourselves and keep it to ourselves, but that doesn't help at the end of life, because many of the times we cannot speak at that time. So for others to see what is it that we wish, what is it that we wanted to do, we need to communicate with our families and the loved ones. So let me just share with you very quickly two okay, so this is the cover of the book. I got that saw that in Amazon. Rose Chast. It's called Can We Talk About Something More Pleasant? This is a memoir that she wrote in 2014. It is pictorial, it is graphic, because she is a cartoonist. So she has put in a lot of cartoons in it to help the discussion and make the point that we need to have this kind of a talk. And the other one is this form. This is the New York State MOLDS form, medical orders for life-sustaining treatment. This is just the first paragraph, just so that you can see what it looks like when you are searching it on the internet.
Khalid, we cannot see it.
Okay, let me see.
I think you're muted.
Yeah, I cannot bring it up right now, but it's
Okay.
if you just put on MOLST or medical orders, it will come up, and each one is a state specific, so that you can find out what is applicable to your own state, because it is slightly different, so that you can then fill them. So I'll stop here, and we will open it up to questions and answers, and I'll let the hosts take over and pose whatever questions and stories that you may have. I know before we started, there are many people on the call who are actually have far more expertise than I do, and I will welcome their comments and additions to what has been discussed so far.
Or maybe a different perspective, Khalid. I just wanted to summarize a couple of things I'd seen. One person suggested making a video for your family when you're healthy, articulating your wishes so that your family can see the video and it's a matter of record. And a question was, if the doctor that you prepared the most with should predecease you, is the document still valid?
Well, like all the other issues, if the physician is deceased, there will be another physician taking care of you. So you do need to have if you are going to develop that MOLDS form, at least in New York State, we need to have a physician or a nurse practitioner from that office help you create it and sign it with their license number, because it is a medical record But other than that, the rest of the documents are not legally binding, they're advisory.
Okay, could the new doctor sort of initial the old most agreement?
I'm not sure, but I would suggest that a new form be developed because I don't see much room in there. These are very tight columns, and I don't think that there is space there to scratch one and put another name there. So it's very easy to replace the first page, perhaps, where the signatures and the names of the physician is, or the nurse practitioner is, and I think that will do.
Okay. For informed consent, have you found this issue difficult for patients who are on significant doses of pain meds?
Yeah, I mean, informed consent means informed consent. You need to be informed. You need to know what's going on, and you need to be able to participate in that discussion before you sign on the dotted line. So someone who is not competent is under the, whether it is due to an illness or due to the effect of medication, cannot really offer an informed consent. So if the informed consent is in relationship to our discussion today, making decisions at the end of life, then that would have been done when the person was fully aware, competent, and had made those decisions. But otherwise, in the general sense, informed consent has to be informed. Otherwise, it's just a consent, and that is, to me, not an appropriate consent.
Okay. Other questions?
Julie, are you able to see the raised blue hands?
I have not been looking at them. Chuck, take over.
Tara, I think you've got the next blue hand. Can you unmute yourself?
Thank you, Khalid. I so enjoyed listening to you this morning. I always learn so much from you. I have two comments and one question. I dealt with end-of-life issues for 18 years in a hospital. And two things, my experience. One is I always went in to ask someone to when I would go in and ask them to sign a healthcare proxy, they would say, "Am I dying?" And I'd say, "No, you're well enough to do it." And when they resisted, I would say, you know, if you're at the end of your life and your loved ones are so upset at the thought of losing you, think of if you have a healthcare proxy who knows what your wishes are, that will make it so much easier for them to deal with your loss. The other thing is that I sat with a woman who was sitting outside her husband's room, and the doctors recommended taking him off life support, and she didn't know what to do. And I said to her, "Did you ever have the end of life discussion?" And she said, "Yes." I said, "What were your husband's wishes?" And she told me. So I said, "The only decision you have to make is whether to follow your husband's wishes or not." And she was able to go ahead and ask the doctors to withdraw to take him off life support. My question is, the most document you said is specific to the state. Suppose I have a most in New York and I go to California. Is that valid in all of California?
Let me first address some of the comments you made, because that's important. Currently, the federal law requires that when a patient is admitted to the hospital, that the admitting office actually check off on a little box which says, does the patient have the advance directives or not? Now, that was a way to encourage people to have advance directives, but I find it I find it wrong. You're going in for a hernia repair, and the clerk on the front desk asks you, do you have advance directives? Why? Am I going to die while I'm in the hospital? What are you going to do to me? So I think being in a hospital, being admitting to the hospital, having sudden illness is a very wrong time. But sometimes we have to do that because that is the only time, because nothing has been done before that. So it's very important that we do this when we are in good health and healthy. And I would urge those of you who are interested in promoting the end-of-life care is to talk to your rabbis and to your priests and ministers to talk about these things in their sermons, talk about this issue when people are healthy and life is not being threatened by any serious illness. Now, in terms of the mobility, my understanding is that this form is portable. You are a New York State resident and you are in California and something has happened. It does provide a kind of it shows that you have had discussions and that the doctor has agreed with you based on your medical history. Now, of course, if you get admitted to the local hospital, your doctor is in New York and is not providing care over there. So I would ask somebody in our, I think we have lawyers in our attendance today. They can tell us, but I would think that some modification may have to be done. But I would say that the doctors in California will look at your living will or your form and will be appraised of your wishes. And I don't think there's any doctor who's going to sort of override your wishes. Now, before we got together, we were discussing this thing and question has come up is that what if the doctor disagrees with you, the new doctor in California? He says, no, I have treatments, I can do this. And or for religious reasons, refuses to carry on the end of life wishes because of personal and religious reasons. And again, correct me if I'm wrong, my understanding of practice in medicine has been that all the doctors, even the hospitals, have the right to refuse such treatments or refuse to agree. But, and that's the big but, is that they cannot do it arbitrarily. They have to provide for the care to be continued either through another physician or through another hospital. And they will have to continue doing whatever they need to do to support you until you are transferred to the care of another doctor or another hospital. So we do have that right, but patients' needs come first and they need to be addressed first. So I think, and I will welcome anybody else who has this legal expertise, but my thinking is that we will, the other doctor will have to follow their state laws.
Thank you.
Elaine, I think you're next. You're muted.
Okay. The most post issue came up in the Affordable Care Act, and that is what that physicians could be paid to have these discussions and do these forms is what Sarah Palin twisted into the death panel. So just so that's the history. I tried to write stuff in the chat and somehow it didn't go out to everybody. It went to Nikki eventually. First of all, I do in living will, I make living will and medical proxy, two different documents tied together so that it encourages people to do the medical proxy. They don't have to think about death right away and they can really get into that. And there are lots of choices, and the power given to the medical proxy is to do or override the what's in the living will, because you can write your living will now and 20 years from now you need it, and there can be other technologies. And so I just tell my clients, make sure you give the power to someone who loves you, because that's the important thing. I also will, in discussing the living will, say it's very individual. And I'll, I have a disabled nephew who has always been having to have a high level of care. His attitude was the disease he had was that he was supposed to die by the time he was 20. And he's now in his 50s. And as far as he's concerned, the longer he is even technically alive, the more he wins the game. So he wants no cutoff. And he said, that's what he's saying now anyway, and then I contrast that with somebody who can't stand a hangnail. It's very individual. And in terms of discussion with the family, I found in my own life that the hardest discussion I had with my daughter was about not only death, but at some point in your life, you accept that it's going to happen. And it's that acceptance thing that was very, very hard for her. And finally, in my medical proxies, I have a phrase that says, I want my legacy to be one of love, not conflict. And should my family ever have conflict over my care, I direct them to go into mediation. So I've never had any feedback about whether that was needed and used or not, but I do know that at the time of signing the proxy, I've had many clients say, oh, I'm so glad you have that. And I would suggest that the Cowboys family and the patient knew that there would be conflict. And it's a shame that they didn't go through that process.
Thank you very much, Elaine. I think that point is worth repeating, is that the living will is a separate document and healthcare proxy is a separate document. And you can combine them together, whatever works for you. But this is something that you have thought it through and this is what you want to do. So I think that is very important. Just another thing came to my mind is that sometimes the word is used, power of attorney for healthcare or healthcare power of attorney,
Right.
which is different than the durable power of attorney or other powers of attorney, which also gives the power to that individual to do financial dealings, pay
Right,
your
the separate
checks.
document.
So
Yes.
healthcare power of attorney is the healthcare agent. They can only make decisions about the healthcare. They cannot sell your house. They cannot get into your bank account.
But my document says medical power of attorney and healthcare proxy.
Right.
And it also includes that other decisions can be made, such as where you will live, because that's part of the end of life care. And there was one other thing I just wanted to say on it, and I just forgot what it was.
Yeah, we'll come back to you.
If you don't mind, let me just mention that I think in order to keep this orderly, if you want to make a comment, ask a question, participate in some other way orally, please raise your Zoom blue hand. If you don't know how to do that, it's usually in the bottom of the participants list, but depending on your hardware and software, it may be a little bit different.
Okay, and I just
We're-
remembered, oh, sorry.
We're unable to see all of the participants' pictures at once, so we need you to raise your blue hand. At the moment, the queue is Stephanie, and then Ellen, and then Carol. So Stephanie, what have you got? Thank you. You're muted, Stephanie.
Now, can you
There
hear me
you
now?
go.
Yeah.
I noticed that everybody's talking about making these decisions with regard to persons, I guess, having family members, and we're just assuming that they have people in their lives. What about those who are Jane and John Does who come into the hospital without any persons and don't have anybody to, I guess, assist them with regard to filling out the forms, or are even cognitive enough to even talk to the doctor and inform him and fill out the forms? How do we go about that? Is there like a system set in place, or do these people just?
Okay. So which sort of also brings up another thing which I did not touch upon. At least in New York State, there is a law that if someone does not have an advance directives and now are incompetent and cannot make decisions, that there is a law, a pathway which is hierarchical, like the wife, if the person is married, or the eldest child, and so forth and so forth, you go down the line. But that is again subject to conflict, and because it is just a hierarchical listing. Now, if somebody comes in as John Doe, Jane Doe, and has no one, that's then you're left with only one party, and that is the physicians to do the best they can. The default always is, I would say always, in medical care is that you do everything. Because particularly in the situation of Jane Doe, you don't know what has been going on. Maybe everything is irreversible. So in that case, most likely, I would think that we will do everything possible while police searches for the next of kin. But I would use medical judgment as to when to stop doing everything possible, when we reach a point of futility. And at that time, many of the hospitals have mechanisms built in, such as an ethics committee and so forth, where you present your issue so that you are not making this decision alone, and that this is a collective decision, but it is still a medical decision because we don't have any input from the family.
Thank you.
Thank you. I think Ellen and Richard are next. You're muted.
Yes, thank you. Yeah, I have two issues I'd just like to bring up. Thank you so much for this presentation. I really would like to validate Dr. Raymond. I'm also a psychotherapist, and years ago, I was what's called a in-home therapist. I'd go to seniors' homes and work with them there, particularly when they were disabled and weren't able to get outside. And so many of my patients, clients then, would tell me that they were completely unable to discuss end-of-life issues with their adult children. It's so prevalent. And I would like to back up that it's really needed. Sometimes the emotional issue of dealing with death can be taken down a notch when you're dealing with legal documents, and that again, to validate that it is so important to encourage people's preferences on end-of-life issues. And sometimes the only way, if it means going to a social worker or a doctor or another relative who's not so close, because it does sometimes seem really impossible and frustrating for family members to deal with these issues. And maybe now after COVID, with so many losses, so many hundreds of thousands of losses and death being on our minds constantly, maybe this will be changing. It's not that I hope it because of these losses, but maybe it's in the air. People are much more receptive. And I have another issue, which can be one of these problematic issues that I once encountered, where in a family, again, it was my role as a therapist, but in a family, the father had indicated he didn't want DNR, and he did not want to be intubated, and he did not want a feeding tube. And that was very clear. However, the oldest daughter made the decision when she was told by his doctor, when he was brought to the hospital, that he would probably die without a feeding tube being put in. And his wife had heart condition, and the daughter was afraid that the wife would have a heart attack if the father died. So she overruled the father's wishes and went ahead and had the feeding tube put in. And then her sister was very angry, and there was a conflict between them. But the older sister maintained that she was just trying to not only save the father's life, but maintain her mother's life as well in that situation. So, you know, when you have that kind of situation, you know, when somebody goes against the wishes because the need maybe to protect somebody else, you know, I'm just throwing it out there as one of these problematic issues.
Thank you, Ellen. I think what you're highlighting is that in a lot of these end-of-life decisions, everyone thinks they're doing the right thing and the thing that the patient would want, and that makes it all the more difficult.
Mm-hmm.
True.
Thank you, Ellen. Next is Carol.
Liebman.
Carol, you may be muted.
Oh, Dr. Listening to you, I just kept thinking, I hope all of us have a physician like you taking care of us at the end of life. It would make all of these conflicts, a lot of them disappear. I've been doing work in this area with Nancy Dubler and Tia Powell at Einstein for a long time. I think about 10 years ago, I talked to this group about bioethics mediation. And for those of you who want to get more into the field, Jenny Besh at the Columbia School of Professional Studies and the group at Einstein Medical School both do courses now in bioethics mediation. And Nancy Dubler and I have a book, Bioethics Mediation, A Guide to Shaping Shared Solutions. I actually was looking at it recently, and medicine has changed a lot since we first wrote the book, although I think the principles of conflict resolution are still applicable.
Yeah.
And when I first started working in the field, I think 15% of the population had any kind of advanced directive or living will, and it's up to about a third now. So there is slow progress toward having people involved in these decisions. But I wanted to make that a shameless plug for my book and let people know about the course if they really want to get into this in more depth.
Yeah, I think the current literature is actually even more optimistic. It's about 56% of the people that have been surveyed have it. So we are moving in the right direction, but it's still taking very long time. It's a very slow pace.
Harvey.
Carol, doesn't Columbia have its own bioethics mediation program with Danny Serviansky?
Danny, so we did teach a course at the law school with the program at Einstein that Danny's involved in. Danny's now teaching with the group at Einstein, and in the COVID era, the course was taught at Einstein this year.
Okay.
But it's a course that's taught by lawyers and bioethicists.
Thank you. Harvey, you're next. Thanks, Carol.
Hey, I'm sitting right across from my wonderful wife. I'm dealing with a wife now who is in hospice, and I think it's a wonderful thing that is really, I think, transforming the field. I'm interested in knowing how the HIPAA laws, in your opinion, have helped or complicated the issue.
Again, I would probably ask one of our attendees who are into the legal system, but HIPAA law is an overall umbrella which protects the privacy of patients' data and patients' information. But over here, we are sharing our personal thing with our personal doctor. And like any other medical doctor, medical orders, it are written in our medical chart. So I think that HIPAA will, it is protected by HIPAA, but it does not get in the way of creating these forms because we are within that framework of, between us and our physicians, and our physician is not revealing this to anyone else.
Right, and can someone like me, as a proxy, health proxy for my wife, fill out a MOLST form for her, or it's only a patient can do that?
You can. So if you look at the MOLST form, particularly the New York State form, in that section, it says who is filling out this form? Is it the patient or the healthcare agent? So a healthcare agent can actually work with the physician and fill out and complete the form.
Thank you.
Sam, you're up next.
Good morning. Thank you to the group for bringing us Dr. Raymond, and thank you, Dr. Raymond, for presenting a very critical subject. I'll try to be brief, but I have a couple of things I wanted to share with you. You mentioned about the difficulty that doctors have in a setting where there's really nothing left to do. My father was a Holocaust survivor who had 3 multiple bypasses, the first by Dr. Michael DeBakey in 1976. He survived for decades after that, but at the end, at a hospital in Florida, they told him there's really nothing left we could do. And I begged the doctor, who was a young African-American woman who I'm convinced was better than all the other doctors, to be a senior attending at that facility. She had to be better than others. but she couldn't bring herself to be dishonest, as she said to me. So I respect the difficulty, and I appreciate the difficulty that doctors have in that setting, because what happened was someone else came in and said, your temperature looks better today, your color looks, they weren't being dishonest. He was still dying, but he lived for a year afterwards because he was definitionally a survivor. But the other thing I wanted to mention was, doctor, everything you said resonated with me. My cousin's wife, 60 years old, in August, we were hiking up at the Mohonk Preserve. She was diagnosed with neuroendocrine cancer, and by the time it was diagnosed, it was widely disseminated. She had stage 4 lung cancer. A 60-year-old woman, absolutely vibrant, did not have healthcare proxy. And I bring this story up because my cousin received, I'm not exaggerating, dozens of phone calls from friends. I have this doctor. I know the senior pharmacologist at Sloan Kettering. They can come up with a cocktail that'll be perfect. And he had to resist all of finally he couldn't. They went to Sloan Kettering in New Jersey. And you know what they told him, doctor? Exactly what you said. They said, you know, the people at your local facility are doing the right thing. There's nothing more we could do for you. It turned into a negative because they went to Sloan Kettering to try and get the best care, and they were told there's nothing that could be done. So my point here is simply that I appreciate the difficulty that you as a doctor and other caregivers have in this setting. And so we have an obligation, I believe, to share with our families, our friends, and our clients how important it is to have these documents in place so that doctors don't have to grapple with this, so that family members, at the very end, my cousin overruled her brother and sister because it was exactly what you described, doctor. You told us about the woman with advanced ovarian cancer. My cousin was on a ventilator for 4 weeks. Finally, she was told, she didn't know she was dying for those 4 weeks. They hadn't told her. She finally was told, and she said, I want to come off so I can speak to my family. And that's exactly what happened, doctor, what you described. She came off, she had wonderful conversations for a few hours, and she passed later that day. But I guess the point of this is thank you very much for reminding us how important it is to prepare these documents for ourselves and to encourage others so that they spare family members and caregivers the difficulty of mediating these end-of-life issues.
Thank you for sharing that, Sam. Thank you.
And I want to add something because I don't think we have any hands right now. My husband died 11 years ago, but I want to reiterate what Khalid said about what I call the revolving door. You tell your story in the ICU to the doctor who's in charge at that time, with all the family ramifications, the history, everything. And then you come back an hour or 2 or 3 or 5 hours later and he's gone and there's a new doctor who doesn't know the story you've already told. So it just underscores the importance of having that video or that written document, whatever it is, that makes it really clear what your family member wants. In my husband's case, he said the thing he was most afraid of was tubes. He didn't want to have tubes. And of course, he did have a lot of tubes. And so I was able to make a decision based on that knowledge, despite the fact that the doctors didn't know him. Get those documents.
Sorry, Julie. I'm also not seeing any blue hands. So let me just ask this quickly. Doctor, from the kinds of conversations you have from your perspective, which is not exactly as a neutral, you do have a little stake in the outcome if the family members are disputing what decisions to make at the end. But can you recommend to mediators who may be in the position of dealing with family members literally near the end of life about the techniques that a mediator could use to help lubricate the conversations among the family members?
Well, I'm not sure I have that expertise, but I think that each situation is very different. Each patient is different, their philosophy is different, their disease is different, the stage is different, their experiences over the years with medical establishment are different. So one has to approach each one of them as a unique situation. And at that time, one can, try to mediate. From a physician's perspective, what I like to do, and I've done, is that I know the patient well. I know the history, I know what has worked, what has not worked. So I would tell the family that this is what my recommendation is. From a professional perspective, this is what I will advise. And I've been put in a very difficult situation many times when the patient said, what would you do if it was your family? It's a good question, but again, it is not appropriate because we are not comparing apples to apples. I'm not in that situation. I can imagine, but I'm not in there. You are really there. So, reality is different. Nonetheless, I would propose to them what I think is the right thing to do, which of course is based on my professional judgment as well as my own view of end of life. But I will leave it up to them to make that judgment, or leave it up to the agent to make the judgment. But I think a role of a mediator is welcomed. Now, hospitals, I don't think have, at least the one I know, or the ones that I've worked in, had any employees as mediators, but they have social workers who are experienced and knowledgeable about this. And we have ethics committees, and we have chaplains in the hospitals who can help relieve the spiritual anxiety and help answer some of those questions. Should we remove the tube? Will God punish us by doing so because we are not feeding someone who will then die of hunger? So those kind of existential questions can be helped by other professionals in a hospital. But sometimes I think we may need expertise from a group like yours, where we have much more. I don't have any particular toolbox that I can share with you right now, which will help your group.
Thank you. Now we do have some blue hands. Yes, Don.
Thank you, Chuck, and thank you, Doctor. I just am most appreciative for this. I've been doing this work for a number of years as a mediator, and what I frequently do, most of my work has been done outside of a hospital setting and has been done with family members who the individual has not left any directives as what to do, and it's usually the person's incapacitated in a state that they can't make decisions, and family members are fighting over what to do. What I've brought into the room is frequently ask them to bring a picture of the family member and ask them each to go around the room at the beginning of the mediation and share what they'd like to hear from that individual, is what they'd like to tell them. And with usually love in the room, they're able to then all come to an agreement. And the statement that I'll make in my opening is that my goal for the outcome is for you all to be able to stand side by side at the end of life, at the grave, or whatever spiritual event you choose, to be able to be together and support one another. And that frequently helps people begin to have a healthy conversation and come back to, shall we say, maybe more sanity, and conflict can sometimes be put aside. Difficult conversations, but I appreciate what you bring to this. It's very difficult work and very humbling work to do as a mediator as well.
Thank you. I think thank you for the organization for this opportunity, because a lot of what has been said in the Q&A session actually is more helpful, because we are all sharing personal experiences and there is no one right answer for these things. So thank you, all of you who have participated in the Q&A and shared your personal stories as well as your personal suggestions and recommendations.
We have one more here, Khalid, if you got one more minute to answer.
I do.
Okay, Janice Tootie Jackson, you're on.
Dr. Raymond, thank you so much. I'm Janice Tootie Jackson, and as well as a mediator, I'm an ordained minister. And a lot of my ministry is around these issues. And so this has been so helpful, so very, very helpful. One of the things that has been difficult, but so rewarding to do, is before it comes to the actual end of life is to work with family members to help them resolve conflicts that's unrelated to the patient's health and status. Because what I have experienced is unresolved conflict in the family, especially among the siblings, the children of the person or siblings of the person, can explode at the right before death, at death, and after death.
Yes.
And can go on for generations. Generations. I have mediated disputes in families that originated about these issues, and the person has been gone 30 years.
Yeah.
30 years. And it doesn't just involve, say it's children of the decedent, that then their children are involved in it, and then their children involved in it. And it breaks my heart when I see it, but it also gives me joy when they can get resolution, even after death, even after death. So thank you so much. You have encouraged my heart. I want to thank you.
Thank you very much for your
Thanks,
kind
Janice.
words.
We are a little after 10. There is another blue hand. So we're officially over. Khalid, if you could stay, can you take a few more questions?
Yes, certainly I can.
So Harvey, you're next.
I didn't expect that. Okay. Wow. Yeah, thank you so much for this. As I said, I'm living with this every day. And I don't even know how to put it. Well, first of all, I think Death Cafe has been such a wonderful opportunity for me to discuss this with people at a totally different level, and I think we need more of that kind of intervention. And I agree with you totally that we should start early in life, not late. It's like after the birds and bees became an issue to discuss in the family, now we have to talk about death. So thank you so much. I just wanted to add one cute story. Just at the beginning of my wife's dementia, one night she said to me, "If I should die," and I just cracked up. And she said, "Why are you laughing?" I said, "If I should die," that's like the first lines of "If I should die before I wake," you know, the prayer that
Now I
the
lay me
children
down
say.
to sleep.
Right, exactly. And we were in bed at the time when she said it. And I said, well, I said, "If is really not the right word to use anymore. It's when."
True. And we don't know when. I mean, it can be in the next moment, it could be the next day. And that's why I have tried, I actually reached out to the New York City Education Department, and I said, "Can you pair me up with parent-teacher groups or something? I would like to go and work with the PTAs and talk to the youth before they graduate from high school." A lot of injuries and head injuries occur when these kids get behind the wheel of a car at the age of 18, and they leave a lot of unsettled things with their parents. And, so not that, so that I thought will be a good time to talk to them and educate them so that they are aware of it and start thinking about it. I absolutely agree with Harvey. An acute illness, a sudden illness is not the time, but that may be the best time, but that is not a good time to have these discussions, because death is looming, it's threatening, and it becomes more of a real thing. When we talk about it when we are in good health, when we are young, then it is not then it's an abstract thing. And it is easy to talk about abstract things at that time, but we can get our message across, we can get our documents in order. And again, I want to re-emphasize, having the documents is important, but making them available to the right party at the right time is also very important. So we want to make sure that once we create them, that they're not tucked away in some drawer where nobody can find them, that they are shared with our families, they are displayed openly, that we can talk about these things openly. As Javi said, it's not if, it's when.
Right. I think that's it. Khalid, Dr. Khalid Raymond, thank you so much. Obviously, this was an important talk and you had a very receptive audience here with a lot of interesting comments. You might be amused to know that someone posted the name and access to the book that you were later going to put up on the screen. Can't we talk about
More
nicer
pleasant
things
thing.
or what less difficult things?
Yeah.
Anyway, this was terrific. Thank you so
Well, thank you for
very much.
inviting me and
Thank
having
you,
this
Dr.
opportunity. Thank you.
Bye, everyone. See you
Goodbye.
next month.
Bye, everyone. Thanks for joining.
Thank you, Dr. Khalid.
My pleasure. Thank you for inviting me.
Raymond,
Dr. Raymond,
thank you so
very
much.
Okay, bye.
Thank
Bye.
you.
Thank you
Oh,
so much.
Janet.
Goodbye, everybody. Hi, Vivian.
Bye.